Okay. The first thing is the pre-course assessment. Pre-course assessment is very important that you will do it before you will come to the exam. It will help you in your study, and it will tell you the main things where how to identify. Let's say it has three sections basically. In the first section, it will help you to identify the ECG rhythms, and in the second one, it's all the pharmacology questions, drugs, medications, and the third one will be scenarios that will combine the ECG, the pharmacology, and your judgment, okay, and how to treat that patient. It's 50 questions. It should take from you somewhere around 30 minutes if you don't know, if you did not read, probably. But it will take really lesser than that if you really understand it. Now, there is a requirement for that, the pre-course assessment. Minimum score should be 70% in each of the three areas. ECG, you have to score 70% and above, pharmacology, and the case scenarios. Where you will find it, this is the link that you will find it. I'll just copy it, paste it for you here so you can save it at any time. But at the same time, guys, it is here. Let me open the camera. Okay, each one of you have the book, and in the book, first on the first page of the book, absolutely the first page of the book, you will find something down here. It tells you what is the website, and it will give you an access. Okay, there will be small access over here at the end. That access on the website, here is the website now open. That access to the website, you will come here to enter the code. Okay, so it will be the ACLS 15. All right, ACLS 15. Then you will submit. All right, sorry. Okay, then this is the mandatory self-assessment. Will start. You write your name and these things. Then you will launch it. In this one, what I want you to do is very important. I want you to watch all these videos. There is airway management video, there is stroke video, there is ACLS video, there is high quality BLS video. All of them you must watch before coming, so we will not lose time there. It's very important. Then you can go and launch your exam, type your name, and after you finish your exam, you must print the assessment, okay, your self-assessment, or at least take a screenshot of the assessment. So it's preferably that you will do it on a laptop. We don't prefer that you will do it in your mobile, although you can do it in the mobile, but we want the anyhow, just bring me something to tell how much was your score, because this will be added to your records in the AHA department. And it's a mandatory thing to get your certificate. Without it, you will not get your certificate. So this one will help you in revision, study, and it's mandatory before you come. So by this, we will finish actually our first thing, the pre-course assessment. Minimum score is 70% in each area. This is where you'll find it, and you will go on. Please watch the 4 videos so we will not lose time there. If you have any question until now, please type your question in the chat, and I will answer you about this area. Before we will go to the next thing, which is the ACLS overall structure. Okay, guys. So, believe everybody is clear on this. Now, let's discuss the ACLS overall structure. The uh, the structure of ACLS is basically you will have. We want you to deal with somebody who will collapse in front of you, or they will call you for somebody who collapsed. You don't know, what's happening to him. But there is a structure on how to save this person. And you should understand what this patient will go through, what caused this problem for him, like he will be arrested, and what course that he will go through. So we will track where is the patient and what we will do in each area. So let's explain it more. A patient who is collapsed, okay, there he is. 1 minute, let me move this one a little bit here. Yes, okay, very good. So a patient who will collapse suddenly, okay, he will go into arrest. This is the line of arrest, we call it. So this is cardiac arrest, basically. Now the cardiac arrest has mainly some arrhythmias in the heart that you will discover when you will put the patient on the monitor. But the main thing is the cardiac arrest line, okay, and uh, the main things that will affect the patients are the patient will go into ventricular fibrillation rhythm, or he will be in something called pulseless V-tach rhythm. Where you will find them when you will do the pre-assessment, you will look for VF and pulseless V-tach, and you will understand it more, how they look like. So if you will see in the monitor, somebody collapse in front of you, then you put him on the monitor and there is VF or pulses V-tach, we will do some things with him. Now the patient still can be, our intention is to bring him back to life, and we have a name for that, or he will deteriorate more and still he will be in cardiac arrest, okay, and he will go into a systole or pulseless electrical activity, two other rhythms. So if I may, right here, do this one, may erase this cardiac arrest. I will write the cardiac arrest over here down. All right, cardiac arrest. Okay, and I will write the VF VF or pulses VTAC. Okay, so these are the rhythms that will cause cardiac arrest. Patient will have no breathing, no pulse all this way, and he will deteriorate more, and he's going to death at the end here. Okay, this is the path of death. Now, if we will find him here, we don't know where we will find the patient, uh, just we will find the patient in arrest. Either he is in VF or pulses VTAC, or he already started over here to go to asystole and PEA. These are all scenarios, possible scenarios for the patient. What we want to do with the patient is to bring him to ROSC. ROSC is return of spontaneous circulation. And we will start with him the post cardiac arrest care. We call it, you will find it in your book as post cardiac arrest care. So we save the patient from being a victim of arrest. This is the first thing that I want you to understand. Patient who will come, VF, pulses VTAC, he might go into asystole or PEA and go to death at the end, down. Or he might go to RUSC. Now, in our practice, if he's in VF or pulses VTAC and he will deteriorate, if he's VF pulses VTAC, we want to bring him to RUSC. If we did not save him still, and he went to asystole, which is worse, and pulses electrical activity, still we will not give up on him, and we want to bring him to RUSC again. We will not give up on him. But there is a structure to do these things. Okay, so for this one now, there are lots of details. Let's talk a little bit about it. You will find first, in your book, there are these algorithms here that will tell you this is cardiac arrest asystole PEA, and this one is cardiac arrest VF pulses VTAC learning station checklist. So let's go one by one a little bit. So basically, a patient who will arrest in front of you, we learned before to what the first thing that we will start is BLS, basic life support. So let me just bring this one up here. Okay, so the first thing we will do is we'll start by BLS. Now, when help will arrive, you will give oxygen and attach the monitor, isn't it? Yes, because help arrive. Now, you are doing 30 compression to 2, 30 to 2, 30 to 2 compressions, and the AEDs arrived and these kind of things. Then now the more help came. So what they will attach the oxygen and attach the monitor or defibrillator. Why? We would like to know the rhythm. What is the rhythm here? Now, in patient who's arrested, as we know, he might be VF, pulses VTAC, or asystole, PEA. The two sides that we discussed about. Let me go back to them. All right. Where are they? Let me just 1 minute. Okay. So they are. Okay. So this is VF, pulses VTAC, and asystole or PEA. This is where they stand. Over here, this is what we want to know. Is the rhythm shockable or not shockable? These rhythms are shockable. They require shock immediately. Once you find VF, you cannot stop and do anything. You cannot tell anything other than load him for shock. How much is the shock and joules and these things? You will find it over here. It's monomorphic and polymorphic. Monomorphic and biphasic. The shock here usually will start by. It depends on which machine that you are using, and we are going to elaborate further on this one on the day that we are going to do the training. So how much shock you will give over here, you can read it in the book. Now, I want tip number 1, you have to remember, after the shock, immediately there comes CPR. There is no delay, no waiting. This one is a must. Shock, CPR. You can shock, CPR. Shock, CPR. So immediately after the shock, you will resume compressions. That's a must. Now, if you will notice over here, there is shock CPR, and it's inside a box here. This one also shock CPR, and the CPR is inside one box. Shock CPR, and it's inside one box. In these boxes, I just want you to remember that the first box, there is no medication. You cannot see any medication. So it's only CPR with IV IO access. Second one is CPR with medication. The third one is CPR with medication. So epinephrine, then amiodarone. This is how it goes. Let's further explain it over here. Okay. So the first, when you identify the patient is VF or pulses VTAC, the first thing you will give shock, CPR, and here we need something called high quality CPR. High quality CPR is, okay, is what you will find over here. This area will tell you what are the high quality CPR components. And in the video, you will find the high quality CPR. It's push hard, push fast, allow chest recoil, minimize interruption, and avoid hyperventilation of the patient. These are the components of high quality CPR. I want you to notice that there are boxes over here. You know, beside each one, there are small boxes. It's box number 1, 2, 3. When you find boxes, it means in the exam we would like you to say these things. I don't want you to say high quality CPR. No, I want you to say shock, resume compressions, push hard, push fast, allow chest recoil, you know, all these things you will say in this circle. This is what we mean by high quality CPR. So the first cycle actually is high quality CPR with no drug. Then after 2 minutes will finish, you will analyze still the patient in VF pulses VTAC, shock, CPR, high quality compressions, high quality CPR. The third thing, after 2 minutes will finish again, shock, you know, you will look at the rhythm, it will be VF pulses VTAC. It will be cycle high quality CPR. Now, the first cycle, there is no drug. Second cycle, there is epinephrine. Third cycle, there is amiodarone. That's what you need to remember. Okay, so for here, we finish the first line for us, which is the VF and pulses VTAC. It's very important to know this. Okay, can I see you, doctor? Yes, it is only the audio, Emily. I'm not there. I'm just showing my, the screen only. Okay, right. Now, when we go the other way around, let's say the patient progressed to being worse, or we came and catch him on asystole or PEA. What we will do, so when we attach the monitor, we did CPR, help arrived, give oxygen, attach monitor. Then we look at the rhythm in the monitor, and it shows asystole or PEA. So what you will do next, there is no shock. It's not shockable. There's no shock like this. You cannot find this here. So what you will do is CPR, epinephrine. Which CPR? It's high quality CPR. Where you will find it? Push hard, push fast, allow chest recoil, minimize interruption, avoid the excessive ventilation. You know, these kind of things you will tell them. CPR, epinephrine. Then after 2 minutes will finish, you will analyze the rhythm. Still the rhythm is not shockable. It will be PEA or asystole. What you will do? CPR immediately. So for asystole or PEA, CPR. Asystole PEA, CPR. Not like the other. VF pulses VTAC, shock, CPR. VF pulses VTAC, shock, CPR. That's the difference. Shockable or not shockable. Okay. So we're going here now. Just remember, The first cycle will be epinephrine, CPR, epinephrine. Second cycle will be CPR and reversible causes, which is the H's and T's. You will find the H's and T's over here. Think of the H's and T's. That's what we want you to remember. Until now, this is all about these things over here. Patient who came, we can catch the patient over here. Nobody knows. Then what we will do, it's asystole or PEA, so high quality CPR and epinephrine. Then 2 minutes finished, there is no shock. Again, high quality CPR and here reversible causes. We will remember the reversible causes and we will consider them and treat them. And they are the H's and T's. We will discuss this one more. Okay. So if you have any question until now on these algorithms, the uh, the application in real life later on in the course we will talk about it. But now I'm talking about how you can understand this piece of information, which is uh, like perfectly designed so you can understand it. Then we will bring the scenarios inside our training at that time. Okay. So if you have no question, very good. We will go and see now what will happen if the patient becomes in something we call ROSC. Okay. This is the algorithm for ROSC. ROSC, return of spontaneous circulation. I want you to remember it as, over here, once we did CPR, we gave them patient medications or so whatsoever. Then after 2 minutes, we found there is a rhythm and we found that there is pulse. So there is pulse means what? Means there is return of spontaneous circulation. We don't need to do CPR anymore. We have return of spontaneous circulation. If there is pulse, what's the first thing you want to do is assess consciousness. Consciousness. You tap on the patient. Hey, are you okay, sir? Are you all awake? And we will understand in the course why we are doing this as the first thing. Why we are doing assessing the consciousness of the patient first. But ROSC is as easy as consciousness A, B, C, D, E. As easy as that. In ROSC, you need to assess the airway, patency, check his breathing and O2 saturation, and the C for the cardiac, you will attach ECG, and the D is for diagnostics. So you will take bloods and labs and these kind of things, and you will send him, for like probably for X-rays and these things. You are looking for the H's and T's more further, and the E, it's the exposure, and the most important thing in the exposure is temperature. We have something called targeted temperature. We need to put the patient on a target temperature, and you will find this target temperature in your book. Okay. The algorithm shows the A, B, C, D, E in a different way. So when you will have a return of spontaneous circulation, let me show you this. So you have a return of spontaneous circulation over here. Sorry, yep, okay. Return of spontaneous circulation. What you will do, the post-cardiac arrest care will start. What we will do, now it says here, as you can see, right? The first thing is, let's start from here. Consider advanced airway waveform capnography. Okay, this one is the A. Consider advanced airway A. So you will intubate the patient and put him on waveform capnography. The second thing you want to you want to do, you want to give him oxygen, but do not hyperventilate him, and maintain the oxygen saturation more than or equal to 94. This is the B, breathing. This box, A and B. We finish the A and B. C, which is the cardiac. In the cardiac, what we will do, we will look for the blood pressure basically. If the blood pressure is below 90 systolic, what immediately will do, you will give him IV bolus. If it did not work, you will give another IV bolus. Where are the how much amount? You will find the IV bolus over here and what to use. Now, if it did not work to increase the blood pressure, you can use vasopressors infusion. Here are they. And all the time here, consider the reversible causes. So this is the C part. Finish the A, finish the B, we finish the C, we correct it. Now, actually here, still, we did not finish the C because we will do the ECG for him to know if it's STEMI or no. If it's STEMI, we will take him to the cath lab. If no, we will follow the rest of the things. Okay, over here, C. Now, the follow of the commands is the D actually. What you will do is draw bloods to consider all the H's and T's over here. You will take bloods, ABGs, you will take troponin, you will take for toxins, you will take whatever you like. Anyhow, you will find it in the book. And the last thing, initiate the targeted temperature management. This one is very important. There is a lot of highlight about it. Okay, targeted temperature management. Okay, so by this one, we will finish our pathways between the cardiac arrest patient, who we found him in arrest, so we might find him in VF or pulsus VTAC, and we know what to do with him. First cycle shock, first cycle high quality CPR without medication, then still VF shock, high quality CPR with epinephrine. After 2 minutes, no improvement, shock, high quality CPR with the amiodarone. Then we're just, later on we'll discuss what will happen if will not improve, whatever things. These are different scenarios. Now, if he will go into asystole or PEA, high quality CPR and epinephrine, then high quality CPR and reversible causes in the second cycle. If he will be better, the patient improved and pulse returned, check his consciousness and ABCDE, as we said just now. Okay. Do you have any question until now about these algorithms? You can type it in the chat if you want. This is until now we are in this area. We are doing the ACLS overall structure. The ACLS overall structure. Okay. Very good. Now, let's continue the overall structure over here. Now, the patient, before he will go into the cardiac arrest or caused by VF or pulsus VTAC or PEA or asystole, and we will be trying to bring him to RUSC, there are some things that he can come to us in the clinic or in the ER or in the hospital that will tell us, hey, this guy, if we will leave him, he might go into cardiac arrest. These are two conditions also we will discuss that they will bring the patient over here. Number one is tachycardia, and the second one is bradycardia. So the tachycardia and bradycardia, you will find them Also, they have their own algorithms. I know that most of the people, they struggle with the tachycardia, but it's so easy, and I can explain it to you when you will come there more, because it needs the practice live, and you will find it is so simple. But now we're talking about the structure of ACLS. So the tachycardic patient, I want you now to imagine with me that we have a patient, and we will discover that he has tachycardia after what? After we will take history from him, ask him some questions first, then we will attach him to the monitor. Then we will see that he has tachycardia. Now, according to the history of the patient, we divide the people, either tachycardia or, let's say, the tachycardia, we divide them to stable people, stable patient, or he may deteriorate or come to us late and he will be unstable. How we will know he is stable or unstable? From the history and from some things that we will do. We want to know exactly when we see, or even before we know that it's a tachycardia, we will assess the patient and know if he's stable or unstable. Let us see over here. Here, the tachycardia, sorry, this is bradycardia learning station. Tachycardia learning station checklist. The tachycardia, it says assess appropriateness of clinical condition, heart rate, typical, whatever they will say. Actually, in this algorithm, where are we going to start? We will start from over here, these areas. We will ask the patient actually some questions to understand if he is stable or not stable from the beginning. So if we have a patient who's coming to you, the case will be like this. You are in ER or you are in the clinic, and one patient came to you complaining of racing heart. Please assess him. So for sure, what you will do for any patient who will come to you, the first step is to take history. You don't want to do anything without taking history first. So when you will assess him, there are specific questions we will give you in the course to ask him. And these questions will tell you about his condition over here. And basically the questions are you dizzy? Do you have chest discomfort or chest pain or anything like that? Do you have shortness of breath? These are the main three questions. And then you will do the blood pressure. You will ask to do the blood pressure and how much is the blood pressure. Any one of them that will be abnormal, he will tell you, I'm not okay, like I'm confused, these kind of things. This is one sign that he's unstable. Chest pain, discomfort, these kind of things, he's not stable. If he will tell you, I have shortness of breath, I cannot breathe, whatever, he is not stable. If the blood pressure is low or whatever, he is not stable. So you did your first assessment. Then what you will do, now you understand that the patient is stable or unstable. If he will tell you all no from the history, he's not. He's stable if he doesn't have anything. If he'll tell you one of them is not okay, he's unstable patient, because it's different way of management. Stable tachycardia, we used to treat stable tachycardia by medications only. Can you hear me, guys? Medications, yeah. And unstable tachycardia with cardioversion. Somebody open his microphone here. Please make sure that your microphone is shut. Okay. All right. Uh, okay. So Here we are again. Patient is stable. If we identify that he's stable, we'll give him medications. If he is unstable, we'll give him cardioversion. Then you can follow up these kind of things. You will give him synchronized cardioversion, these kind of things, if he is unstable. Now, if any one of these things will appear, he becomes unstable, which is yes, you will give him synchronized cardioversion and go with the algorithm. If he is stable, which is no, all these things are not present, what you will do, you want to know if the QRS is wide or narrow. If it's wide, if it's narrow, here is the way. This is narrow QRS. You will insert an IV line, 12 lead ECG, you will give him vagal maneuvers, adenosine, whatever. But if he is he is wide QRS complex, you will go through this one and consider antiarrhythmic infusions. Where are they? The medications: procainamide, amiodarone, sutalol, PAS. We will give it in more simplified way when we are there. But now, due to time limits, this is what I want you to remember. Basically, I want you to remember from now until we will meet: tachycardia, stable, we will give medications; unstable, cardioversion. If you will remember this one, that's it. Because an unstable patient can go into arrest. This is his pathway. He will go. So you have to be careful. From stable, he will be unstable, then he will go to VF or pulses VTAG, be in cardiac arrest, whatever it is. Now, the second person who will come to us is the bradycardia. Still, the bradycardia is stable. He can come stable or unstable. Same way. But the bradycardia is more easier to treat, or let's say not to treat, to understand. Better to say it like that. To understand. Why? Because we are going to follow the same system of the tachycardia. We will know by history, okay, and when attach him to the monitor, if he is stable or unstable. It's the same thing over here. The same questions. Do you feel, um, you know, you will know if he's confused, if he's altered mental status or anything, some questions. You can ask if has just discomfort or anything like that, difficulty breathing or anything like that, and blood pressure. You need to understand this and look for the signs of shock for sure. When you are examining him, the history and examination. Now, if he is having all these things normal means stable. What you will do? Just monitor him and send him to the clinic, to a cardiologist. There is nothing to do in bradycardia that much at this course, at the level of this course. But if he is unstable, that's the time you will start to do something. What is it? You'll start to give atropine, and here's the dose, 0.5. The maximum dose is 3 milligrams. So you'll give atropine every 3 to 5 minutes until the maximum dose is 3 milligrams. Now, what we do usually is atropine will give the first dose. If it did not work, second dose, it did not work. Then we will prepare immediately for the transcutaneous spacing, because this is the ultimate treatment for the patient. It's not the atropine. The ultimate treatment is transcutaneous spacing. Now, while they are, or you can do dopamine and epinephrine, but in this course, we would like to hear from you transcutaneous spacing, because we want you to do it. Just remember this, okay? Transcutaneous spacing is the ultimate treatment for bradycardia. Now, if you don't have transcutaneous pacing. You can do dopamine, you can do epinephrine, but mainly think of this one. After the patient is okay or whatever you start him on, please expert consultation. Guys, remember all the time, expert consultation is the main thing in tachycardia and bradycardia. If the patient will be stable or unstable and you corrected him, you need to inform the cardiologist. If tachycardia, you find him tachycardic, stable, you treated him, or unstable, you treated him, and he became okay, you will need to tell the cardiac physician. The expert consultation is a must. Okay, so by now we finish the two other algorithms that will get us into arrest. So we detected the patient that he has bradycardia or tachycardia before he arrested. And here is the whole scenario. Patient comes to you, tachycardic. You took history from him, you did examination, you hook him to monitor, you found him either stable, you want to give him medications, unstable, you want to do cardioversion. You could not catch him at that time, he will go to, or you did not treat him well, he will go to VF or pulses VTAC, then you have to do shock, high quality CPR, no drug, after 2 minutes still on the same thing, and you will follow the same scenario. Or the patient will come to you bradycardic, he can be stable or unstable, you catch him from the history, examination, and monitoring. And if you will not treat him, he might go to VF, pulses VTAC, then he might deteriorate more to asystole or PEA. And if you're lucky, you will bring him back to ROSC. If not, nobody knows, you know. But all the time you want to bring people to ROSC and assess their consciousness, A, B, C, D, E. Okay, so if we are okay until now, just little things more about the overview. If you have any question, you may type that question. Okay, so from here, as you can see, the ACLS overview structure is the diagram that we wrote. And things to remember, very important things to remember in the algorithm. If you are in arrest mode, high quality CPR plus or minus drug, that's your main thing that you will do. There is high quality CPR and plus or minus drug. There will be shock or no shock. Probably you understand it when you will see the rhythm. In ROSC, please remember it's consciousness A B C D E, and it's the airway. Airway, breathing. I'll just change this one to breathing. Breathing, cardiac things, diagnostics, exposure, which is the temperature. Then the tachycardia and bradycardia. Now, the tip for tachycardia and bradycardia is, if you see this, MUSI 12, is something that will remind me of what I need to do for the patient all the time. It's just a simple tip. I'll show you where to use it. So we have a patient who came to us, and when we are asking him in the history, let me just point it to you here. A patient who came, we ask him, and in the history and through examination, and hook him to the monitor, we find that from the history and examination that he is stable or unstable, whatever, stable, let's say. So we decided to call someone to help us. How many people we will need to call to help us in tachycardia? There are mainly 3 people. We need 3 people to help us in tachycardia. 3 people to help us in bradycardia, and 5 people plus the leader, which is 6 people, to help in cardiac arrest. You need a total of 4 people for tachycardia, total of 4 people for bradycardia, total of 6 people in cardiac arrest. So you are the leader, 1. You need 3 people more. The 3 people more, you need to assign some work to them. The first, you will find it, the work to assign, you will find it here. Okay, so let's say bradycardia. In bradycardia, you will find you need 1 person to maintain the airway open and give the patient oxygen. Two things, 2 tasks he will do. Maintain airway open and give oxygen. The second person will hook the cardiac monitor and give you 12 lead ECG. This is the second person. And the third person will be in the IV for IV access. So if you will see it, it's written MOCI 12, MOCI 12. Now it's just a way to remember. Just a way to remember what are the things that we need to do for the patients. And as you know, guys, when you will see these arrows, these boxes, box here, box over here, boxes over here, this means in the exam, these are mandatory things to do. If you will do it, we'll take yes, he did it. Then we will go further in the practice and in the exam, which means that we want you to see the patient and assess him, get history from him. Then if you decide to bring people, you will assign them according to MUSI 12. You will assign the patients, the people who will come to you to help you according to MUSI 12. You maintain airway open, give oxygen. You connect him to cardiac monitor and give me 12 lead ECG, and you give me start an IV for the patient. This has to be a second nature for you. We're expecting that it's supposed to be second nature for you if you'll see tachycardia or bradycardia as a leader. Okay. Now we will go further into what is the thing about ACS and stroke? Why ACS and stroke are here? Well, you will find that where is the ACS here? If the patient has acute coronary syndrome, what will happen? He might develop arrhythmia in the form of, okay, let me just take it like this, in the form of bradycardia or in the form of tachycardia. And if the patient will develop also tachycardia or any other things, the patient might develop stroke. Okay? Or stroke can happen by itself. But we want you to be aware also that stroke can happen from something over here that we have. The algorithms for stroke and stroke management and ACS, these are the things that we really want before the tachycardia develop or bradycardia to develop. These are the things that we really want to treat. Now, are they in the megacode exam? No, they are not in the megacode exam, but they will come in the written exam. Where you will find the videos for them, here they are. When you do the pre-course assessment, there is an ACS video, lower left, and there is stroke video. When you are reading the stroke algorithm or ACS algorithm, please open these things. Timing is very important and crucial here. on when you will treat the patient and these kind of things. Okay, so now I'm remaining with my last part, okay, in this presentation, which is where to find the scenarios. Where can you find the exam scenarios for mega code? On your book, I'll just open the camera so you'll see me now. Okay, on your book, at the last, in the last pages, there's appendix. The first thing is for BLS. This is the checklist for BLS. This is same what we have to pass you in the exam or no. There is airway skills, the second page. Then we will start the VF or the mega code exam over here, and I will show it to you how it will come. Okay, it's all available for you with all these kind of algorithms. So where we will find it again, let me show you. Okay, let's just take this as an example here. See, your exam will be, I don't know what scenario you will pick for yourself. You will choose something. Okay, at the back of the book. Yes, yes, Emily. It's at the back of the book. All right. Yeah. Okay. At the back of the book, you will find these papers that you are seeing now on the screen. As you can see, for me as an examiner, I will follow what you chose. So if your paper became bradycardia, then pulseless VTAC, then PEA, then post cardiac arrest care. So this is your pathway. Let us see how is your pathway going on with in the full structure that we draw already. Let me just bring it here near to me. Okay. So this student will have, we will start by giving him a scenario of bradycardia over here. Now, most likely it will be unstable bradycardia. Then, as you can see, bradycardia over here. Then what? It's pulseless VTAC. So the patient will go to be pulseless VTAC, cardiac arrest due to pulseless VTAC. When he will see the monitor, it will be pulseless VTAC. What we are expecting from him is to shock CPR, high quality BLS CPR with no medication in the first 2 minutes. Then 2 minutes finish, we will not change it. It's still what he will do. He will check the pulse because, pulses VTAC. He will see VTAC. He needs to check pulse. Then if there is no pulse here, he have to shock the patient. Pulseless VTAC. No pulse, shock, high quality CPR, and epinephrine. 2 minutes finish, check the pulse, no pulse, shock, CPR, high quality CPR, and amiodarone. Then the rhythm will change according to what he chose to PEA. So we are going on this direction now, down. So it will be PEA. What we're expecting is CPR, high quality CPR with epinephrine, 2 minutes, then 2 minutes finish, he will check. There is no pulse because there is PEA. PEA, you need to check the pulse. It means pulseless electrical activity. Pulseless VTAC, pulseless electrical activity. So pulseless electrical activity, there is no shock. Okay, you will give CPR, high quality CPR, and reversible causes. Then the patient will go to post cardiac arrest care. Finally, he will go on this path. The patient will follow this path to ROSC. which is we want him to start by finding the pulse, consciousness, A, B, C, D, E. He will go through it, then his exam finished. How we will tick as an examiners? Okay, let me show it to you. Here are the things to tick. At the bradycardia time, here it is, bradycardia. Did he start oxygen? Did he place the monitor and proper positions? You know, this one, when you will say these two, when you will say MUSI 12, you'll find MUSI 12 will save you in these two. Then recognize that the rhythm is bradycardia. Then administer the correct dose of atropine. Then prepare for the second line treatment, which is the transcutaneous pacing. If you did, I'll take correct, 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 correct. Now, if something you did not do, if you did not go to the second line treatment, well, and I change to the rhythm to pulses VTAC for you, I want you to recognize it. I will put yes. You recognize this is pulses VTAC. Then you will go through all these things. We will do whatever you are doing well. At the end, we will change again to PEA, recognize it. We want you all the time, guys, if you can see, recognize that this is symptomatic bradycardia. You have to tell the people, hey guys, we have bradycardia, unstable bradycardia. You have to tell the people all the time, where are you? Are you in stable bradycardia or unstable bradycardia or anything? Okay, these things are very important. Then uh, um, recognize that he's in pulses VTAC. Recognize he's in PEA. Identify that he's in ROSC. You have to say it. So when you will say the things, we will put tick. And if you will not do something, it will be open. Anything open means you did not pass. You need remediation. And the remediation can be in the same day. If you will fail 2 times in remediation, you have to repeat the course. But if you will get past, that's it. You'll finish your exam and you're good to go. Okay, let's have another just a scenario. Don't save it. Okay, let's see. What is this? This is bradycardia VF asystole RUSC. Then probably this one is tachycardia VF PEA and RUSC. Like that, it will go. So by this, guys, I finish the presentation for today. Okay, if you have any question, here's the overview. If you have any question, please, you can type it. All right. And tell me if you need any help. But for now, that's it. This presentation is done, finished. We'll stop the recording.